The last piece that I think we're early days on this, but I wanted to bring social determinants of health into the field of view here, largely because CMS is bringing it into the field of view. Something we didn't touch on with respect to the changing sort of reimbursement environment. As of 2025, we're going to start being graded on our ability to reduce disparities, and we're going to be looking at screening members for these SDOH issues. So there's ample reading that is easily found. This is from health.gov, the example that I've got here. But we know that some of these populations that do have greater health disparities, we know less about them. And that's where it's going to start to sort of double hurt us, is if we don't know and we're being graded on our performance with them. So it becomes a real petri dish of, we have got to start creating experiments to where we're getting more sophisticated than, well, one, we're getting more sophisticated so that we can be effective with the member. Two, we're getting more sophisticated because someone in the market is going to, and we want to be getting those high star ratings so that as attrition naturally happens at the end of a year, we are the de facto go-to plan. We're the plan that has all of the high ratings, and we're starting to get the attrition from other plans that might not have done this homework. Just for an example on how the sort of correspondence can be used in instances like ethnicity in this case, but Engages had done some work that NCQA actually cited, where looking at a call to action being asked and using a couple of methods like specific ethnicity information, leveraging a male voice, both were put together in the form of Hispanics are at a greater risk of, and it went on to discuss whatever ailment or likelihood might be out there. Both of these tactics improve screening rates. If we know that and we're starting to look at these populations and be graded on them, that is unquestionably an edge to get more members involved and an edge to have that higher star rating than some of our competition might not. I mentioned earlier, but this can feel sort of spooky because we don't know this space as well as an industry. We sort of know it as a topic, and as candidly, like, I think it's been more of an idea than it has really been put into practice. But as it starts to be pertinent to star measures, look at the opportunity, not just the challenge. The data to be creative is totally on our side with this. I mentioned that census data, vulnerability indices are out there. Just looking at zip codes and starting to marry some of these things can then give us the power to say, we should be writing a different letter or doing a different test in these zip codes than these other ones, because they're fundamentally different audiences with fundamentally different obstacles that they're trying to overcome. We did some light work with this. One of the kind of early tests that we had done where we brought some of that CDC data in and found that when trying to nudge people to use a provider search tool, we did actually have a 13% difference in the utilization if we were looking at zips that were defined by or categorized as impoverished versus if we were looking at outside of poverty zips. So I think that's then where the interesting and creative work goes to say, okay, if we're in an impoverished zip code, what does that look like from a real member's journey? And how can we address what that world looks like to the tune that the provider search tool is now actually beneficial, as opposed to something that might feel heavy or just feels like it gets lost in the noise? Without leveraging data and looking at this, we would continue to sort of pump the messaging with equanimity across both of these zip code cohorts, and we're simply leaving opportunity on the table. We're underperforming in some of those zip codes where we don't have to be once we're made aware of this.